Welcome to Practicing Clinicians Exchange podcast. Progress in prostate cancer, a focus on PARP inhibitors. Today's episode features Brenda Martone, a nurse practitioner at Northwestern Medicine in Chicago, Illinois. Ms. Martone will summarize key evidence on PARP inhibition in prostate cancer and offer practical guidance for using PARP inhibitors in the clinic. This information was presented as part of a series of presentations during a recent PCE Oncology conference. After listening, please visit pce.is/ONC22 to access the slide sets from the conference and additional related activities, including a series of interactive patient case simulations focusing on the application of PARP inhibitor therapy in clinical practice.
Hi, my name is Brenda Martone, and I'm a nurse practitioner working in GU Oncology at Northwestern Medicine in Chicago, Illinois. I wanted to spend some time today discussing the role of PARP inhibitors in metastatic CRPC. We know that BRCA1 and 2 mutations and other germline mutations are associated with an increased risk of prostate cancer. And we know roughly 11% of men who have metastatic prostate cancer do have a germline DNA repair gene mutation, irrespective of family history. There's also somatic mutations in DNA repair pathways in 19% of localized cancer patients and 23% of those with metastatic CRPC tumors. And our focus today is going to be on that metastatic CRPC tumor patient population. We know that all men with metastatic prostate cancer should be offered both germline and somatic testing. But what about some other considerations in populations who we should also consider germline testing? And that would be in patients who have high risk or locally high risk disease, any family history of prostate, breast, or selected other cancers, anyone with an Ashkenazi Jewish ancestry. So again, it's very important when you're seeing your gentleman to also inquire about family history, as this may guide decisions regarding germline testing. It's important that we understand the test that we are ordering for our gentleman. So we need to know if this is doing germline, somatic, or both. PARP inhibitors are approved therapies for patients with BRCA mutations in metastatic CRPC. PARP and BRCA are involved in DNA repair damage. There are currently 2 approved therapies, olaparib and rucaparib, and it's important to understand their approval indications are a little different. In the PROfound study, which was a phase 3 study that led to the approval of olaparib, there was a longer progression-free survival with patients being treated with olaparib and reduction in the risk of death. Rucaparib is our second approved PARP inhibitor. It was based on the TRITON trial. The patients in this study that obtained benefit were those with a BRCA mutation, either 1 or 2. What was seen was the overall response rate was approximately 43.5%. So the indication for olaparib is for adult patients with deleterious or suspected deleterious germline or somatic HHR gene mutated metastatic CRPC who have progressed following treatment with either enzalutamide or abiraterone. Rucaparib is approved for adult patients with a deleterious BRCA mutation, either germline or somatic, in metastatic CRPC, and these patients must have received treatment with either an androgen receptor director therapy, which is either abiraterone, enzalutamide, darolutamide, or apalutamide, and a taxane-based chemotherapy. How do we choose therapy when a patient qualifies both for olaparib and rucaparib, both based on indications and previous treatment? Some things to consider would be comorbid conditions, looking at past medical history, obviously reviewing medications to look for particular drug-drug interactions. That may help determine which therapy would be more appropriate with fewer dose modifications. Also asking patients their preference. Again, the side effect profile is similar, but there are some differences between the 2 agents. So having a conversation that allows for mutual decision-making and asking the patient which treatment they would prefer if options exist. I had a patient come see me in clinic one day, and he was on olaparib and actually doing quite well. He came with the question of why his friends in his prostate support group and those on Facebook online were all taking rucaparib, and he was not. I took the time to explain that he had previously been treated with enzalutamide, which is a second generation AR inhibitor, and he had disease progression. He had a BRCA2 mutation, so he could qualify for both. But looking at the dose indications and the prescribing information, I explained to him that he had not progressed on docetaxel chemotherapy. Thereby, he was unable to receive rucaparib. But olaparib was an option for him because he did have metastatic CRPC progressing after a second generation AR inhibitor, and that's why we started olaparib. And he was very comfortable understanding why that choice was made. The administration of both agents is oral. Olaparib is dosed 300 milligrams by mouth twice daily. It can be taken with or without food. Rucaparib is dosed at 600 milligrams twice daily and can be taken with or without food. For olaparib, we need to keep in mind that patients should avoid drinking grapefruit juice, eating grapefruit, Seville oranges, or Seville orange juice. There are no restrictions with rucaparib. The most common side effects we see with rucaparib and olaparib include anemia, fatigue, and GI toxicity. Anemia is the most common toxicity reported both with olaparib and rucaparib. You want to monitor your CBC with DIF closely. In my clinical practice, I often monitor the CBCs at the beginning of therapy every 2 weeks. And as treatment is continued and counts remain stable, I do extend that interval out to every 4 weeks. If I do see anemia developing, I want to make sure that I'm ruling out for other causes such as iron deficiency, bleeding, or any chronic kidney disease that might be contributing. If the anemia becomes more severe, I'm going to consider holding my dose, wait for that anemia to resolve to the patient's baseline, and if necessary, consider a dose reduction. If the anemia becomes severe in terms of below 8, I'm going to consider transfusing my patient with red blood cells. Fatigue. This can certainly impact quality of life as well as function. I want to rule out further common causes of fatigue and not just assume it's related to the PARP inhibitor. I'm going to look for if there's any hypothyroidism, underlying cardiac disease, anemia that we just talked about. And if all those other things are ruled out, then I want to encourage my patient to increase their physical activity, keep good oral hydration, yoga, and rest when needed. If the fatigue does impact not only their function, but instrumental quality of life ADLs, I'm going to consider holding a dose, seeing if that fatigue improves, and then resume that dose depending on the severity of the fatigue at the same dose or perhaps a dose reduction. The most common GI toxicities that we see are nausea and vomiting. The nausea and vomiting seems to be the worst at the beginning of treatment and actually gets better with time. You might want to consider using prophylactic antiemetics, and this would be recommended that the patient take it 30 to 60 minutes prior to each PARP dose. So as the PARPs are dosed twice daily, we need to remind our patients to take their antiemetics twice daily. We need to avoid aprepitant with those taking olaparib, as there is a strong CYP3A4 interaction. Some other recommendations that we can make besides antiemetics, perhaps taking their PARP inhibitor after a meal to reduce the risk of nausea. If vomiting persists despite all of these interventions, encouraging the patient to keep a food diary to help identify triggers. In severe nausea and vomiting is not typical with a PARP inhibitor, and other causes should definitely be investigated. I have a patient who is on olaparib, and he had mild nausea at the beginning of treatment. It didn't impair his ability to eat, and his weight was stable. It was somewhat bothersome for him. He didn't want to take any prophylactic antiemetics. He preferred the fewer medications as possible. So we did talk about taking the PARP inhibitor after a meal, and he decided to keep his food diary to see if there were any foods that he could identify. He found that taking the PARP inhibitor after a meal did reduce his nausea. In fact, the nausea resolved relatively quickly and has no longer been bothersome. He didn't identify any foods that were a trigger, but he was pleased that the nausea improved with a simple intervention. He also noticed at the beginning of treatment worsening fatigue. He was still able to work, still able to do all of his activities. It was more annoying and nagging than anything. So he continued to remain active and increased his oral hydration. And approximately 2 to 3 months after starting treatment, his fatigue had actually improved, was no longer noticeable or bothersome for him, and he was doing well. There are new and exciting things coming down the pipeline, as always. Some of the clinical trials that are coming are looking at combining these PARP inhibitors with other second-generation AR inhibitors in the metastatic CRPC setting, looking at moving the treatment up earlier in metastatic CRPC, and also looking at some additional PARP inhibitors in this setting. These are all very exciting events, and we're looking forward to being able to offer our patients additional therapy and choices in the future. If you would like to find some additional information, please visit the PCE website, practicingclinicians.com. And I encourage you to learn more with patient case simulations that are designed to provide practical experience in managing prostate cancer, metastatic CRPC, and PARP inhibitors.
Thank you so much for listening today. We hope you enjoyed this podcast and invite you to participate in other activities related to PCE oncology conferences by visiting pce.is/ONC22.